Well, hi everyone. Thanks for the intro, Steve. My name is Ben Katz, and as Steve said, I'm a senior project manager of dashboard projects at the CUNY Institute for Implementation Science and Population Health. And today I'm joined by my colleague Anay Patel to talk to you a little bit about our work on the Ending the HIV Epidemic dashboard, or as we more commonly refer to it, and you may have heard it before, called the ETE Dashboard. Um, and I'll get to what Steve said, because there's some truth in that some of the work that we do with the ETE Dashboard was born out of the work I was doing and we were doing with New York Links. It's not just a story. Um, so today's webinar, I'd like to provide an overview of the dashboard, including the scope of the data and information available on the site, and how to find the data you need or you're interested for your work. Anay will then take you on a deeper dive into a couple of our interactive pages and demonstrate how to use these visualizations in your work. So for example, where to find your region or your county level data, and then even looking closer in at key population data, such as by age group or race ethnicity. We'll discuss some ways people have used the dashboard in the past in their work. We will ask you if anyone has been, visited the dashboard before and you have suggestions or ways you've used it in your work, and then we'll have some time for Q&A at the end. So whether you're already familiar with the ETE dashboard or this is your first time being introduced to the site, we hope that after today's webinar, you will all have a better understanding of how to navigate the site and use the data in it that's most relevant to your work. I just want to, right before I go on, I just want to make sure folks are getting on their screen, what I'm sharing with you. It's a browser window. It's most of the, presentation, the webinar today will be Anay and I, demoing and going through the dashboard site. So yeah, I just want to, hopefully if anyone problems, maybe chat to Steve in the chat. Yeah, if there's any issues there, but yeah, you want to definitely see most of what's on the browser on your own computer right now. Thanks. Okay, so just briefly, I'd like to touch on the origins of the dashboard, and a lot of that info, or some of that info, how and why we launched the system, is even included in our dashboard about page. So that's just by going up to the top navigation menu and clicking on about. The concept of the ETE dashboard was born or came out of a recommendation of the 2015 blueprint to end the AIDS epidemic in New York State. So some of you who are been working in HIV in New York since then will be very familiar with that time and the blueprint that came out and the initiative that launched in 2015. When it was released, it explicitly called for the need to expand and enhance the use of data to track and report the progress on the ET initiative. And it recommended creating a web-based, public-facing dashboard system to broadly disseminate all this information to our stakeholders. So with that in mind, our team here at CUNY, with the support and collaboration of the AIDS Institute, began to design and develop the ET Dashboard platform, a public website that could routinely monitor whether New York was on pace and is on pace to achieve the goals of this initiative, the targets of initiative, and to share those findings or disseminate those findings in ways that would be accessible and useful to a broad audience. And just a note on what Steve said earlier, that design and development probably started even before this dashboard work started, because on New York Links, we were generating care cascades and maps that presented, some of the stuff we'll talk about later today around linkage to care, retention and care. And we were doing it as we've always done it on PowerPoint presentations or PDF reports. And this new dashboard system was a way kind of to make that all accessible and real and clickable. Like just anyone from sitting whatever, as long as they have computer access, could go on the website and find a cascade or find a map to see this data without waiting or having to find it through folders or emailing departments, etc. And over the years, the AIDS Institute, this is important to that, in collaboration and coordination with ETE stakeholders, has identified a slate of official metrics to track progress towards ending the epidemic in New York. And these metrics, ETE metrics, are updated on an annual basis. You may have heard about them or be familiar with them as they're presented every year at the New York State ETE Summit around World AIDS Day. And we at the dashboard publish them or display them on their own dashboard page. So under the ETE metrics page. We're not going to do a deep dive on this page today, but I did just want to do a little overview because these are the official statewide metrics. And this page is it's one of our most viewed pages because of that reason on the dashboard site. So looking at this page on the left side, you see a menu that has each of the metrics. Users can, toggle between this menu to find the metric or the chart they want associated with each metric. On the right side of the page, we have a menu to more customize this data. So you can view the data by statewide or citywide. Some of the metrics have demographic filters, such as by sex, age group, or race ethnicity. Not all of the measures or ET metrics have these. It really depends on what data is available to us and what can be made public here. On the chart itself, we have a blue line. I'm going to go back to statewide here. A blue line represents the actual data from year to year. The orange line shows the annual target set out by New York State, and the purple line is the end goal for the initiative. So for example, just looking at PrEP use right now, if a user hovers over the last data point on the blue line, they see 50,558 individuals in New York State filled prescriptions for PrEP that year. And while we see the overall trend is, gradual increasing, we're still short of the 65,000 goal that was set for the official metrics. Sorry. I'll just quickly note too, there's a gray bar here on the chart that flags 2020 as a year that a lot of the data was impacted, obviously, by the beginning of the COVID-19 pandemic. And like many of the charts and pages you'll see throughout the dashboard, there are always chart notes with data source information, definitions, and this page particularly because it is the official ETE metrics. There are several notes, things to keep in mind about the data, caution for interpretation, etc. The last thing I want to mention on this page is this thumbnail image on the bottom right. And I will click on it. If users click on that image, it takes you to a report that is sort of the official report fact sheet put out every year that the DOH AIDS Institute publishes that combines all of these metric charts into one document. So if you want to see each metric and the data for statewide numbers in one place, that this report is available through the site. Okay. Before I hand over the reins over to Anae to demo some of our other interactive pages, I do want to just spend a couple of minutes going through what other information is on the site and how to navigate to those pages. So as I said before, we have an About page, but also under the About section of the dashboard, we have a page for data sources, which gives brief descriptions on the different data sources that we pull data from throughout the dashboard. This might be helpful if you have questions, again, on where the data is coming from, how it's accessible, maybe in more raw form, and etc. We also have an acronyms page, self-explanatory. If you come across acronyms across the site and not sure what they represent, here's just a reference for them. I'll come back to data in a little bit because that's the main content, but I just want to show you all our ETE implementation page. So here's a page where we've put some tools and resources that try to help answer the question of what is New York State doing to end the epidemic, as opposed to how. And for example, one of our like signature or most featured pages or tools on this page is the ET Policy Tracker. The ET Policy Tracker documents legislation and other policy updates that have impacted ETE related recommendations and HIV in New York in general over the years. Again, I'm not going to do a deep dive on this page today, but I do encourage folks who are interested in what happens in Albany and policy related work to spend some time on this page after the webinar today. The page is currently organized by Blueprint AIM. So for example, if you click on a section around find the first linkage to care and health, and looking at these orange circles, it shows a policy event or a policy update in that year. I think there's some more recent work documented in the Getting to Zero timeline. Yeah, so again, the orange circle represents a policy, like a piece of legislation enacted, and clicking on it gives you more details about that work. So anyways, it's just a tool for those interested in policy work and policy changes over the years with ETE. Going across from implementation, we have our ET blog page. We update this on a monthly basis, more or less, to feature program highlights, new data on the dashboard, and also the National HIV Awareness Days. For each awareness day, we tend to take data that we already have on the dashboard and create some infographics from them. We post these on the blog post, we put them on our social media pages, and we also I'll post the link at the end of the webinar. But in order to see our updates on the blog post page, you need to be subscribed to our email list. So if you're not already, I encourage you all to sign up today. We'll have a link at the end of the presentation. Also, you can always go to sign up, the blue button on the top right section of the website. Okay. And lastly, under resources, we have, a more traditional type of resources page, different links out to other websites, resources on general information, testing, PrEP and PEP. But we also, under this section, have our infographics page. And that, again, is what I just described a minute ago, where during these HIV awareness days, we publish infographics for sharing. Around the ET Summit, World AIDS Day, we do an end of the year infographic to sum up all the data updates for the previous year. But yeah, if you follow us on social or get our email blogs, you'll see these infographics. And if you miss them, we do save them all on this one page in the resources section. So all that said, the main content of our dashboard work is actually data, as I described before. That's our mission. And the ETE dashboard not only provides the statewide official metrics I showed earlier, but also serves as kind of a one-stop shop or clearinghouse for all HIV-related data in New York. So whereas in the past, someone would have to go to different sources or reports to find data on HIV testing, or new diagnoses, or deaths and hospitalizations, we've made it our goal at the dashboard team to bring all this data and make it available to the public and put it in one place. So we've organized this content accordingly. We have a right side menu where a user can kind of browse quickly down in these different sections, or as we call them, data realms, from testing to new infections, prevalence and care. And then under each heading, we have different subheadings, and each of these point to a different dashboard page. So let's say you're interested in HIV prevention. So I'm going to go back up to the prevention section. These subheadings, PrEP use, PEP use, regional PrEP aware fact sheets, condom use, mean that we have a separate page or separate place on the dashboard for each of these items. And a user can kind of click to browse through each of them. Under each highlight, we show the measures, or so the type of data you'll find on that page, the years of data that are available, the geographic level, so whether we have statewide, regional level data, or even down to county or borough level, and then filters. So, whether or not you can filter, stratify the data by certain demographics or other risk information. And then the blue button takes you directly to that page. So for example, I'll click on it, and you can see you go right to this new data visualization page. Okay. What else? So, the last thing I wanted to say about our data directory page, because there's a lot going on here, is at the very top of the page, we have these highlights and this list tab. You're looking at right now on my screen the highlights view of the page, but we also have a list view. So a user can toggle over to the list view, and all of the same information I just sort of showed is here, but in a more straightforward list view. And I recommend this version of the data directory page for folks who know exactly what they're looking for, aren't here necessarily to browse all the data that's on the dashboard, but want to, quickly look, scan what we have and get to that page as soon as possible. Might be easier if time is an issue. Okay, I am gonna stop my screen share now. I am going to, I think Ane is going to take over, and while he's getting set up, and he's going to take you on a more detailed tour of some of our interactive pages. But as he gets set up, I just want to make one final note about data and data sources on the dashboard. So most of the data on the dashboard is a population level. So it comes from a citywide or a statewide survey that should represent the overall population, or from HIV surveillance data, which includes data on all diagnoses or lab results in a given, geographic area and reported to the Department of Health. But since many of you, or if not all of you, work at clinics or supportive services organizations, when you're looking at data, you're looking at program data or data just for your client or consumers. And it's just important to remember when we're comparing numbers and rates at our own organizations to these wider surveillance data, you might see, large differences, and there's good explanation for that. For example, the linkage and retention data in surveillance could appear much lower in some cases than the outcomes at your own clinic, where you're doing more follow-ups and it's part of your patient population. So that's just a note of caution for folks new to comparing organizational data to population level data. And on that note, yeah, Ane, why don't you take it away?
All right. Hi, everyone. Once again, my name is Anay Patel. I'm a project assistant at CUNY working on dashboard-related projects. So I want to take a sec to touch upon a couple of the interactive pages that we have here on the dashboard. The first one will be the new diagnoses cascade page. So this is at the statewide level. We also have a city-specific page that I will touch on shortly. But the measures that are present on this page are the number of new HIV diagnoses, linkage to care within 3 months and 30 days, and viral suppression within 3, 6, and 12 months of diagnoses. And then you can also view the data at this page at the statewide level, at the Ryan White region level, and at the county level, and filter by age, sex, and race and risks. So taking a sec to actually look at the page itself, at the top of the page, you'll see these 5 boxes that are data highlight boxes. So these showcase all of the data for the measures that were previously mentioned. And as well as they also feature some of the key ETE metrics that Ben had mentioned was on the that separate ETE metrics page. So those include the actual number of new diagnoses, linkage to care within 30 days, and viral suppression within 3 months. In the default view, this page shows data for the entirety of New York State for the latest available latest available years worth of data. So this is showing data from 2022. These boxes are then translated into the cascade diagram that you see on the left-hand side of the page. They have the same data that's present in the top, just in the form of the stacked bar graphs. So if you hover over these, you can actually see the counts as well. So you can see that out of the 2,313 new diagnoses in New York State in 2022, 1,866 were, or 81%, were linked to care within 30 days of that diagnosis. To the right of this cascade diagram, we have a map view, which by default shows it broken down into Ryan White regions. This map shows one of the indicators present in these in the 5 top boxes, by default showing new diagnoses. However, by toggling on the indicator tab to the right-hand side, you can switch to show any of the other indicators as well. If you want to view older data, you can also change the year within the top of the filter menu as well. Data can also be shown excluding New York City if you want to look at the rest of the state population, and also be stratified by any of the following demographic filters. So sex, age, race, or risk. For example, if you're interested in the Black population in New York State, by stratifying by Black on race, it actually updates all of these top boxes and the cascade and map diagram to show your selected demographic group. Furthermore, if you're interested in a specific region, by clicking on that region on the map, you can see at the top, the boxes change to orange, and that's showing data for your specific region. On the cascade diagram, you can see that it adds orange boxes, once again, showing data for your specific region. Again, next to the blue bars, which show data for the overall statewide rates. You can also choose to view data at the county level. However, we do not allow for stratification by demographic filters at the county level due to low numbers present in many of the counties. But once again, if you're interested in Buffalo, you can click on Erie County and see the overall county rates compared to their statewide averages. So you can see here that 90% or 56 people were linked to care within 30 days in Erie County, compared to 82% at the statewide level. The map at the county level will be suppressed depending on the indicators that you select, due to, once again, the low numbers present here. So any of these suppressed counties have actually less than 5 new diagnoses for that given year, which makes the percentages that would be present in the cascade a lot less statistically relevant. If you're interested in New York City data, there's a couple ways to access the New York City specific page. From the data menu, by clicking on the New York City tab, you can link straight to the New York City page here. However, if you're already on the state page, by clicking on the New York City area on the map, or by selecting New York City from the region menu, you'll receive this pop-up that links you straight to the New York City page. This page is set up identically to the state page with an obvious focus on specifically the city. Functionally, the borough level is the same as the Ryan White region on the state page, where you're able to stratify by any of the following 4 filters. Once again, by also allowing you to compare your specific target population and borough versus the overall citywide rates. So here we can see that 84% of Black New Yorkers in Brooklyn were linked to care within 30 days versus 77% overall citywide. You can also view data by UHF neighborhood. This is, again, functionally similar to the county view on the state page. where you are not able to stratify by any filters due to overall low numbers present in some of the UHF neighborhoods. Again, the map can also be suppressed depending on the specific neighborhood due to less than 5 new diagnoses for that given year. And if you're interested in viewing any of these indicators temporally, we also have, going back to the main data page, next to the care continuum, we have a trends view page, which takes those indicators and plots them on as a line graph over a several year span. So you can, any of the indicators that were present on that page, including, on the other page, including new HIV diagnoses, linkage to care, and viral suppression rates, can be plotted on this chart here. You're also able to compare different demographic groups against each other as well. So for instance, this is the linkage to care rates for men versus women from 2010 to 2022. And mousing over or hovering over the data points gives you more information. So for example, this is showing that 81% were linked to care among 1,876 new diagnoses amongst males in New York State in 2022. Okay, so the second page that we wanted to show off was our PrEP use page. So this page is actually showing the number of persons who filled at least one PrEP prescription within either a 12-month or a 6-month period. And that data is able to be broken down at the statewide level, at the Ryan White region level, and in the city level, the citywide level, and the borough level. So taking a second to look at the page, you can see that we're able to switch from annual to semi-annual time periods via the filter menu here. The region toggle, once again, is able to stratify between New York State, excluding New York City, and just New York City. At the state level, you're also able to compare different Ryan White region level, different Ryan White regions against each other. So, for example, this is showing the rates, the number of PrEP recipients in the Central New York region versus the Finger Lakes region. You can also select the total population, which includes both Medicaid and non-Medicaid recipients, or choose to view only by Medicaid recipients. Also, just to mention, we're actually working on a slight cosmetic update to this filter menu. Functionally, it will be the same, but if you do check back in a couple weeks, it might look a little bit different. Again, you're able to stratify by different demographic filters here. So at the statewide level, if you select sex, you can look at the rates or the number of PrEP recipients amongst males versus females. One thing to note with our when filtering by race on the PrEP page is the data source for this page is actually a prescription database. And due to that, there is a lot of incomplete or missing age or racial groups. So if you look at the data broken down by racial, ethnic, or racial and ethnic groups, you can see that one of the highest trend lines is missing or unknown category, due to the fact that there is specifically for race a lot of incomplete data. So just something to keep in mind if you're utilizing this data for any of your work. Lastly, I just wanted to show off a new feature that we are going to be implementing across the site. So currently, the only way to select counties is by physically clicking on the county on a map, and it will display that data on the left-hand side of the page, depending on which specific data view page you are looking at. However, starting with the epidemic summary page, but again, will be rolled across site-wide. We've implemented a county search feature. So on this page, if you didn't know where exactly the county you're looking for is on the New York State map, you can simply type in the county on this search bar, and it will highlight that county and display its associated data. So that wraps up our demo portion of this webinar. So now I'm gonna switch it back, hand the reins back over to Ben, who will start touching on some of the various use cases that we have that people can use the dashboard for.
Thanks, Anae. I saw there were a couple hands up. I don't know if anyone has questions that are particular to what we just demoed in the last few minutes. If it might be a good time now then to try to address those if that's the case.
Yes, so if people have questions, they should absolutely put them in the chat box, and then
Okay.
we'll get those up. While we're waiting for that, though, let me ask you the same question I ask every data person,
Okay.
and that is, I have a couple of them actually, but the biggest one is this. So the most recent data in the dashboard is 2022.
That's correct.
And today is February 29th, 2024.
That's correct.
So why isn't the data more recent?
So the way surveillance, and most of the data that we're showing right now is surveillance data, but so the data is collected from lab results and diagnoses, and it goes into the Department of Health. It takes necessary time to follow up on all that data that comes in. So for example, the data set that closes for calendar year 2022, that data doesn't get frozen or closed off till May 2023 or something. It takes the set of months after that calendar year ends to follow up, do data quality checks. Then the data that we get at the dashboard, is released around December. So again, that's about an 11-month, like it's to your point, Steve, that's about 11 months after, the end of 2022 ends. So what's amazing is that it's 2024, right? And we're putting annual data up. So we're not going to get the 2023 data till the end of 2024. So it's that 11-month lag time or even 12-month lag time. I don't know if anyone remembers, but years ago, it was more like 18-month or 20-month lag time. We've actually, I will take, we, with the dashboard and making this data accessible in public, actually decreased the time lag, to get this up there. That's one reason, just the amount of work it takes for the steps involved for doing quality control, follow-up, the epidemiologist and folks at DOH and NYC, DOH, to prepare a public data set. And that's one issue. The second issue just is for some of the measures that have follow-up time. So let's take linkage to care within 6 months of diagnosis as an example. If someone is diagnosed with HIV in November of 2022 or something, we're counting the percent of those people who were diagnosed in that month who is linked to care in the next 6 months. We can't even answer that question until 6 months later in the data set. So that is another reason for time lag for some of the proportions or percent outcomes that we put on the dashboard. I realize it's a challenge for anyone trying to get up-to-date data. Yeah.
Well, it is and it isn't, because I always, my follow-up to that question is, most of the programs out there have their own data, and that you should use surveillance data to inform where you would look at your individual program data. Because if we're talking about improvement or grant writing or any of that, your own data is perfectly fine. It's not as parsed or worked over as surveillance, but I've looked at a lot of self-reported data, and it is comparable to surveillance. So it's within a percent or two usually. So it's not a problem. So Ben, we would expect 2023 data to be available when? January, February 2025, roughly?
2023 data will be available as the ET Summit World AIDS Day 2024.
Okay, so December, early December 2024.
This coming December. So that's the last time we did the major update on the dashboard. So we're already 2 months, or I guess 3 months past that right now.
Yeah, okay. Somebody wanted to know if there's a way to stratify data by more than one filter.
Yeah, so I just put it back in the chat box. It depends on the page you're looking at. For new diagnoses, the numbers tend to be very low at a county or even region level, where the numbers are so low we can't stratify them. But for example, on our HIV care cascade page, you can at a region level say do sex by age or age by race. So it does depend on the measures you're looking at, and the type of data.
And Nancy O'Keefe says that sometimes the ETE dashboard data is different from the New York State DOH data. Is that possible?
So it's very possible, and it's very possible considering we also receive our data from NOIS.
That's why I asked it that way. Yes.
I wouldn't say one is more accurate than the other. There's always going to be small differences in the way something is being calculated and the definition of a measure. I mean, and sometimes this is in the finer details. I'd say just as a more practical answer to this question for everyone, if you see a discrepancy and you're doing work and you need to understand why, sometimes just feel free to email me or and literally send a message. I mean, the reasons they differ, Nancy, are different depending on what the data is or what the measures are. So there's sometimes different answers. And sometimes even it depends. I mean, this isn't always the case, but occasionally we get our data set, to prepare for that update in December. And then later on, the DOH might update numbers they have they have a more recent data file that they're updating numbers. But on the dashboard, we're on this plan where we just kind of update it once every year for the surveillance data.
And I know that when surveillance publishes data, it often has footnotes, which talks about which better defines some of the areas in there. And I know you have that carries over onto the dashboard, but I would imagine for a lot of the areas where you then kind of repurpose the data, you would also include footnotes about definitions and how you're managing that, correct?
Correct. So okay, I'm glad we stopped and did a few questions. We're a quarter to 12. I do have a couple slides to sort of wrap up.
Sure, go ahead.
So I'm going to go ahead and talk through this for the next, 5-7 minutes, and then we'll do some more Q&A if there's any that come out of this, and then wrap it up. So yeah, why is this useful? How is this useful? We've talked about a couple examples so far. There may be others we don't know that you all know that we don't even realize when people are using information or data for the dashboard in their work. I do encourage anyone actually right now, if you can think of a time you have used info or data from our site, to just maybe put in the chat box how you have. So one is setting goals and targets for your organization. With the caveat of all the limitations and differences sometimes of what your clinical or program data looks like compared to what's in surveillance, it still can be helpful as a reference point to look at recent trends, maybe in your county or your region or even statewide. And what are some of the statewide targets put out for these data? So, I just put in an example from our ETE metrics page here on the left of viral suppression among newly diagnosed HIV. The goal has been set at 75% of those newly diagnosed would be virally suppressed within 3 months of diagnosis. There was an upward trend, for many years. We hit a snag during the pandemic, and we'll see how, the next couple of years of data if it's rebounds and continues on that upward trajectory. But that's just a long way of saying, you know, for different plans and strategizing, in your work, sometimes we're not sure what the right goals or the right targets are to set, but what the state has sort of, branded as their ETE metrics might be helpful, and that can all be found on the ETE metrics page. On a super pragmatic and practical level, using local data in a grant or funding application. We all know that in our work, when we want or need more resources and support for the work we're doing, there's a need to describe the need or the burden of HIV, or the burden of whatever the issue or problem is that you work in. And as simply as grabbing some numbers or data from the dashboard, even screenshotting a chart, so you can use a visual to actually make the case. Visuals are really powerful, especially for, in policy level decision making, funding, resources decision making. People respond to visuals. We are working back. We used to have more share functions on the dashboard, so you pulled up a chart or a map and you could, without having to use your own screen capture or screenshot kind of software on your own computer, we had a way to download charts. We're trying to work that back in. We had some issues in the past. So for now, it does rely a little on your end of like printing screen and citing the dashboard. For example, working on building that tool back into the site. Other uses, presentations and reports. So what does that mean? For the same case I just made, it doesn't have to be a grant application. You might be doing reporting and you want to build in some context or background information around, again, probably most likely around the geographic area you work, but also sometimes around the population you work with. If it's young people or women, or for whatever it may be, we have that type of key population level data on the dashboard available. We mentioned earlier on the policy tracker, so advocacy, you could use information on the dashboard to, again, help you make a case if you're doing advocacy on why a problem is, overlooked or bigger than people think it is, and maybe even describing what's been done in the past and where there are gaps. Trainings, this depends on the work you're doing, but we know whether it's around data, like data literacy, helping some of your colleagues to, help understand data better. It could be grabbing a chart or a map off the dashboard, using it on a slide, showing it, having a discussion around what does this mean? What do people think this means? So we found that it's been useful in staff trainings before. What else? That was my prompt to you all. If anyone had examples, I can't see my chat box for some reason, which is annoying. But
So actually, yes, Nancy O'Keefe again says she works in the Nassau Suffolk EMA.
Okay.
And while she has access to data on Part A consumers, to get Long Island data, she uses the ETE dashboard.
Okay, great.
That's the only example we had come up in chat.
Okay. All right, let me continue. I mentioned before the infographics. This is just another example of, where something might be useful for you in your work. If you're doing advocacy or you're trying to describe problems or putting together a report, even though we like to think of our visualizations, our maps, and our charts as pretty, we have a graphic designer that we work with sometimes to make it even more pretty and more engaging. So we'll take some data and highlight it into infographics. So this, especially when it pertains to like health disparities and differences. So here's just two examples of disparities, by race and PrEP use, and also concurrent AIDS diagnoses and HIV testing among people age 50 and up. So we encourage folks to share our infographics. We do post them on social media and use them in your work. So what are we focused on now? What sort of our priorities? What type of work are we doing? One of the latest, newest pages we've done on the dashboard was around social determinants of health. We decided not to do like a longer demo of this page today, because its own category. But this past December, we launched this new page that featured social determinants of health alongside HIV-related outcomes, displayed by county in New York State. This tool is accessible from our main data page. It allows users to compare ET metrics such as new diagnoses, viral suppression, with social and economic measures like poverty, education, housing cost, insurance status. And in presenting these data together on the dashboard, we aim to highlight the importance of how structural and social inequities where people live are associated with key disparities in HIV-related outcomes. We know from looking at HIV surveillance data that HIV has we know in our work, a disproportionate impact on some communities. And it's time that we can actually visualize and display some of the factors like poverty, education, housing that might help better understand why these disparities continue to persist. And so from the dashboard perspective, we're just continuing to think about ways to visualize this information, to provide evidence to things that people talk about a lot. But if we have tools and visuals to kind of back up what we're saying, I think it could help in work and policy, etc. And we're always looking for welcoming feedback on this tool. So if people get a chance after the webinar to visit the SDOH page, if you have ideas or suggestions on what kinds of other data you'd like to see shown on the dashboard, that would be good to put in the feedback form that we're about to post. Actually, Anae, while I'm talking, if you could actually put the Google form link in the chat. I don't know if anyone has to leave early or anything before I get there. That would be great. Before I wrap up, I want to mention our other main dashboard that's pretty relevant to HIV work, and that's our Hep C HCV dashboard. It's similar to ETE. We're focused on presenting data related to eliminating HCV in New York State. We have diagnoses and treatment cure data on that website, so I encourage those interested or who work in HCV to check that out as well. And then finally, we're running out of time. We all want you to stay connected to us. We mentioned our email list. Here's my email as well as the ETE Dashboard email. You can scan this QR code to get to subscribe to the email list. As we said earlier, you can just go to the ETE Dashboard and use the sign up button on the top right. That'll take you directly to the same page to put your email in. We will not be bombarding you with messages. It's once a month, sometimes twice, sometimes every other month. It's not too much. And then we are also on X and Instagram and LinkedIn. We put out updates, our blog posts, new data on those platforms as well. It leaves us a few minutes for any Q&A. And lastly, Anae put it in the chat, thanks. But here's the link to just help us improve this. We talked with Steve. Hopefully there's, need or interest in us doing this again, maybe, this year or next year. We can cover other areas of data, other information that's on the dashboard, not just what we did today. And we're just looking to improve how we can present this work to you all, how we can help make it useful. So you can scan the QR code or click to this link, or it should be in the chat as well. So I think that about wraps up what I have to say. I don't know if there's any other questions or not.
There was a question.
Let's see if I can see this.
The question was from one of your long lost cousins, evidently, Sandra Katz. says you mentioned to be careful to use things like linkage as compared to an organization's linkage services. Can you explain what the issue is?
Maybe we can both help to explain. So I just interpreting comparisons with caution. I guess what I mean is when we report a linkage percentage for a county or a region, 82% of people, newly diagnosed were linked to care within 30 days. I remember this, especially with working with New York Links, and I assume it still happens with people working on quality improvement reports and other things, that sometimes people will look at a number or a proportion or a rate for the region they work in or the county they work in and say, wow, that's like either that's really different than what we have at our system, or that's much lower. Why is it so different? These can't be the same things. And there's different reasons for that. Sometimes it's because those numbers that we put out on the dashboard from surveillance include folks that are in and out of systems in different healthcare facilities, whereas some organizations who have much higher linkage numbers, there's it's your clinic population or your for example, so you're doing follow-ups, and that's just one little example. I don't know if that rings true for anyone, or
Yeah, and one of the issues also is just definitional. I remember
yes, yeah,
there were big issues about, especially with linkage to care, because it was 30 days from diagnosis. It's okay, well, when does the diagnosis happen? Some systems say the diagnosis happens when the person is told at the point of testing. Others say, no, no, no. Only our medical provider can diagnose somebody. Somebody giving a test, a diagnostician or a outreach worker cannot diagnose people. So it's not until that person sees our clinical provider that they become, and clearly, as you can imagine, if it takes 2 weeks between the test and seeing the medical provider, and for the organization, when they see the medical provider, that's when the 30 days start. That's a very different measure. And so the state often is using actual lab results. So for the state, it's when this information hits the lab, and that's what so some of it's definitional. It's just how you define specific steps within the process. So that's one of the other reasons why it can be tricky to try to use some of these kinds of measures. I know when I was at HRSA, we were reporting HRSA retention data, which thankfully isn't that big a deal anymore, because retention is not as an important thing now as it was then. But HRSA had a retention measure that was but people had to be seen twice in the year, once in the first 6 months, once in the second 6 months, with a 90-day gap between visits. So if you were seen May 1st and you were seen June 30th, you were not retained because there was not that 90-day gap, even though you had the 2 visits, one in the first, one in the second. So it's some of those kinds of things, and that's where my question around the footnotes, really read the footnotes to see how a measure is actually being defined. I'll use the state cascades for people in care. The state defines people in care as people with lab work that's been done, using the logic saying that, well, you wouldn't have lab work unless a provider ordered it, unless you saw the provider. So that's the logic for the state. We all know that two things, that you can get lab work ordered over the phone or by email, and secondly, that you can see the provider a bunch of times and not have lab work done. So you have incidences of care, just not that don't meet the state definition. So there's things like that statistically, whoever puts the data together has to make decisions around what they're going to use to define parameters.
Yep. Yep. Yeah, if we had more time, we could probably go into some of the ways that we sometimes misinterpret charts, and otherwise, yeah.
Right, or where there's just where we all know that the actual percentage is higher than what we're measuring, but because we have to measure it with things that are actually measurable, we kind of allow that to happen. Because it allows us to be consistent from year to year to year, month to month to month, rather than something that may be changing and more fluid. I don't see any other questions in the chat box. And since it's 12:02, we're going to move on very quickly, and then we'll bring this to an end. So I want to thank Ben and Anae for doing the presentation today. If any of you who are in attendance would like to see something further, email me, and we can put it together. And Ben, let's talk about what other options. Maybe we'll do the Hep C dashboard. We've never done that. That's an option. Just to give those of you who are left some idea of what we have, when I say we, New York Links has coming up. We're doing a lot in the next couple of months. I'm not going to run through it because I see the number of participants decreasing on a second-by-second basis. There's a lot going on. Let me just point out that we're doing a new model for New York Links. We're getting away from regional meetings and going into a conference model. Our first conference is at the University of Rochester on March 26th from 10 to 4. We will have 15 sessions of stuff, three sessions concurrently each hour. So it's a lot of content. We'll be doing quality improvement content. We'll have provider-based content, consumer-based content, some around data. So keep an eye out for that. Otherwise, this is what we have going on. It's a lot of stuff. I should probably find a way to send this to people rather than we do things individually. Let me say this. If you are here because you got a direct email from us about this, you don't need to do anything. If you are here because somebody said, oh, you should come to this presentation, this webinar, and now you want to see like one of the things that's up on the screen, email me. Send me an email saying, I would like to be put on the New York Links mailing list. My email is right there in the upper right. Or you can go on the New York Links webpage, and there's an email link on that. Email me and just say, I'd like to be put on the mailing list. I will have your email because you've emailed me, and I will have your name, so that's all I need. And I will add you to the specific regional list, and then you will get these. Unlike Ben and the ETE dashboard, we will bombard you with emails because we have a lot going on. So you'll get probably a weekly email from New York Links about a webinar or an event or something that we're doing. All right, thank you all. It's almost 5 after. We'll put an end to this. I'll end the recording.